Good morning. Welcome to the Department of Medicine Ground Rounds. Today we have a special guest who's going to talk to us about population health, an area that is becoming more and more and more important, and its definition is ever changing, I think, to add more and more things to it because it's quite a complex issue. And this person has actually established a Population Health Institute, and I think we're going to learn a lot about that today. I want to let the audience know that this week was match week for the students, and that we did very well. We match entirely. I can't tell you who we match with, but every year the quality and the students that we're getting is just increasingly tremendously, and we're very proud of this group of people. The school in itself, I think, matched over 97% of the students match all across the United States, and we're very happy for that. So we'll find out soon enough. Now, today, back in 1944, on this day, was the birth of Erwin Neher, N-E-H-E-R, who was a German physicist. And Dr. Neher shared the Nobel Prize with Berg Sockman in 1991, and basically what they did is they found ways to measure how an ion channel works, how the ion channel opens up and allows molecules to go through. But today is about population health. It's not about cells. And that is interesting because Dunn and Haynes said population health refers to the health of a group of people, but it's greatly influenced by social, economic, physical environment, childhood development, behavior. And whenever I hear the word behavior, I think about psychology. Two people were born on this day in the early 1900s that have changed a lot of our thoughts about motivation and behavior. Number one, Raymond Cottrell, born on this day in 1905, who was an English-American psychologist who conducted research on issues related to cognitive ability, personality, and in fact he developed a number of psychological tests to evaluate personality, and motivation. But my favorite is B.F. Skinner, and some of you have heard me talk about Skinner just this past month, who I learned about in college. B.F. Skinner was a famous psychologist, behavioralist, and social philosopher, also born in early 1900s, 1904. So these two people actually developed their careers very coinciding in time and influenced each other. But Skinner was interesting because he believed in the idea that human free will is an illusion. Human free will is an illusion. He felt that behaviors are really causal factors that are influenced by consequence. You do something, it's a bad consequence, you don't repeat it. And he went on to say that positive and negative reinforcements were very important to determine behavior. And in fact, he said it is a mistake, and I repeat, it is a mistake to suppose that the whole issue is how to free man. The whole issue is to find ways to control him. Isn't that interesting? And I think that's an important concept, but it's a concept that is often misunderstood. The way I read that is if I put our students and our trainees in the right environment, surrounded by the right mentors, and give them the right motivation and reinforcements, they will grow up to be outstanding physicians and people of value in society. And by the same token, I believe that if we put people under the right reinforcements, motivations, and environment, we can change behavior towards a behavior that promotes health. And hopefully some of this we'll hear about today. And with that, I will introduce Dr. Barbara Casper, the Division Chief for Internal Medicine, who's going to introduce our special guest.
It is my pleasure to introduce this morning's Grand Round speaker, and this may actually be the first time that the parent of one of our current faculty members is presenting our Grand Rounds. And so I'm delighted that Dr. Paula Stillman has joined us this morning. Dr. Stillman completed her undergraduate degree at Barnard College, followed by a medical degree at NYU School of Medicine. Her residency was actually in pediatrics at Boston City Hospital, followed by a chief residency at University of Arizona in Tucson, Arizona. Dr. Stillman's CV is replete with leadership roles beginning at the University of Arizona, where she was the director of the pediatric clerkship to assuming the role of Dean of Curriculum at the University of Massachusetts and Dean and Provost at Eastern Virginia Medical School. She most recently has served as Vice President of Healthcare Services and Director for the Institute of Population Health at Temple University in Philadelphia. Dr. Stillman has been an innovator in the use of standardized patients in medical education and is also interested in quality and safety as well as population health. She has numerous publications to her credit and is on the editorial board of multiple journals. She's a sought-after speaker on a national and an international basis, and I'm quite delighted that she was able to join us this morning for her presentation of population health. What does that mean? Dr. Stillman.
Thank you. Thank you very much. I'm delighted to be here this morning, and I'm especially delighted because 2 of my children are in the audience, so that puts a lot of pressure on me to do a good job. I'll kill them afterwards. So I want to talk to you today about a subject that's near and dear to my heart, and that's population health. And okay, good. So what does population health mean? And we talk about the triple aim, and our goal is to improve health, reduce illness, manage healthcare resources. And the triple aim is improve the health of the individual, improve the health of a population, and do this at a decreased cost. And it's really hard to do all 3 things simultaneously. We can probably do 2 things, but the third one always gets in our way. But when we talk about population health, we have to talk about the full spectrum, from wellness to prevention to acute care to chronic care and then to end-of-life decisions. And I think it's really critical that each patient have a single point of contact, and that's really the concept of the patient-centered medical home, where there's a primary care physician who controls all the threads about an individual patient and knows what's going on with that patient. Now, the problem is that we're living in 2 worlds right now. We exist in a fee-for-service environment, and we're moving towards global capitation. And depending where we are on that continuum determines what our incentives are, what the reward systems are, what the carrots, what the sticks are, how payment is determined. And it's very hard to be right in the middle of this seesaw, and we have to figure out what's the tipping point. When do we act as though we're living in a fully at-risk capitated environment? So if we look at the continuum, we move from fee-for-service, then to gain sharing, then to risk sharing, which is negative, and then to full capitation. And I've looked at this from the perspective of a provider, from a patient, from a health system, from an insurance company. And you really need to follow the flow of money and figure out who's the customer. And above all, you need tighter horizontal and vertical integration. And if I'm using words that are not understood, please raise your hand, because I really want all of us to understand the same concept. So what are the facts? Acute care hospitals are moving away from revenue generators to a cost center. We used to say, put heads on the beds, and now we're closing beds in acute care hospitals, and it's partially a failure of our healthcare system when a patient has to be hospitalized. Occupancy is decreasing. What many acute care hospitals want to do is put the most specialized, highest paying patients in the hospital and keep the rest of them on the outside. And post-acute care is becoming increasingly important. When a patient gets out of the hospital, we want to prevent them from becoming frequent flyers and recycling back into the hospital. So if we look at how the current healthcare dollar is spent, about 35% goes to the hospitals and only 33% goes to the doctors. And this is really going to change. So I think as we move forward, the winners are going to be primary care physicians, and we really need to change the reimbursement system for PCPs, ambulatory facilities, home health care, post-acute care facilities, and physician extenders. So we save our physicians for the task that physicians alone are capable of doing. The losers are going to be specialty hospitals and subspecialists. So I live in Philadelphia, and in Philadelphia, there are 7 heart transplant programs, and only one of them really has sufficient volume. The rest don't. Some of them do 10 cases a year, 12 cases a year. They're on the verge of losing accreditation, and that's an incredibly expensive resource to have in the city when these cases should be clustered at 1 or 2 facilities. So I think we all know the problem. Healthcare costs are increasing. A small percentage of patients use a disproportionate share of resources. Physicians' time is used ineffectively. We spend a lot of time on the telephone. We spend a great deal of time with paperwork, things that we didn't need to spend 12, 16 years of education to accomplish. And high-cost facilities are very inefficient. If we look at sites of care, I like to use this pyramid because we should provide care at the lowest cost setting that's capable of providing that care. So we should not be taking care of community-acquired pneumonia in a tertiary care facility. And then if we look at health professionals, we should use the super specialist for what that super specialist is uniquely capable of doing. And we should use people who are less expensive for other roles. So we should use the right resources at the right time, all of the time, provide care in the lowest cost setting, and use each level of healthcare provider to his maximum level of competence or licensure. So 20 years ago, 30 years ago, a number of you were in practice in this room, and we would have a group of doctors in an outpatient setting, and there could be one shared nurse and one shared medical assistant in the practice. And today, we could have one primary care doctor and have multiple layers of people below that doctor, several RNs, several medical assistants. I'm going to talk about community health workers. And it's critical, especially with the shortage of primary care doctors, that we shift non-clinical work away from the primary care physician to other healthcare providers who can accomplish that work. About 2 years ago in Philadelphia, I developed a program utilizing community health workers, and I want to share with you some outcomes of that program. Now, this is not a new concept. Years and years ago, when we first went to China, there were barefoot doctors right at the time of the Mao Revolution. And these were people who lived in the community, who provided some level of care for community people. We recently went to Medellin in Colombia, and there were a lot of community health workers there. They were called promotores in Hispanic-speaking countries. And the problem with community health workers, if you look at the literature, there's no standardized name for this job. There's no standardized curriculum. There's no standardized job description. There's very limited certification or accreditation. There's no requirement for continuing education. There are no standardized competencies. And most of the literature talks about process data. So did patients get health screening? Was a hemoglobin A1C drawn? Was education given for smoking cessation, but not outcome data? Not did that patient stop smoking? Not was the diabetes under control? Just was the blood drawn? Was the education given? And I want to show you a video that we made when I was at Temple. If I can get this to work. Jason? All right, help me with this, please. What? Okay, we tried it out before, so it should work.
Well, it did work earlier. Froze the.
we want to go back one slide?
Yes. Go back, sorry.
Temple University Health System is one of the nation's leading academic medical centers. It offers patients access to some of the most advanced treatments available today in cardiovascular care, cancer, pulmonology, digestive diseases, transplantation, and robotic surgery. Temple is also the leading safety net hospital in Pennsylvania for a low-income population, many of them on Medicaid, who are a large part of rising healthcare costs nationally.
We live in an area that has many patients with multiple diseases who utilize the hospital and the emergency department inappropriately, who don't take charge of their own health care, who don't know how to navigate the system.
With Medicare now penalizing hospitals for readmissions within 30 days of discharge, healthcare systems face an uphill battle to control unnecessary visits and to curb the costs they incur.
It's a tremendous economic impact. If we can keep these patients out of the emergency department, first of all, we decompress the emergency department. We don't let them get sick enough so they need to come to the hospital, and we save the costs of the emergency department and the hospitalization.
Temple is meeting this challenge with a new program to train and utilize community health workers.
Utilizing community health workers allows us to take people from the community, train them to interact with people in the community, activate these patients, and get them much more active in managing their own health. What we'll do during the training process is we'll teach you interviewing skills, we'll teach you how to communicate with patients, we'll teach you about cultural sensitivity, we'll teach you how to help your patients access resources that they need in the community. And mostly we want people who are highly motivated and who view this as an opportunity to advance in the healthcare field.
The first class of graduates is already producing positive results.
It's me, Miss Treadwell. How you doing? Did you take any Tylenol or anything? Maybe she could call you in something for the pain.
Yeah, I can't go get it. I'm telling you, I don't even know how I'm going to make this appointment with Dr. Commodore this morning.
I can email Dr. Tan directly from here and tell her that you're experiencing a lot of pain.
I was in the hospital, in Temple Hospital, and that I don't know what number of time that was, because I was in and out, and I spent 3.5 months in rehab trying to learn how to walk again and to get used to my hands, because I couldn't even hold a glass of water. It just slipped right through.
She wasn't coming downstairs at all because she wasn't strong enough to come downstairs.
And scared to come down, because I really do have steep steps there. I was in really, really bad shape when I first met her.
And my job particularly was just to come here, check on her, make sure everything was okay.
And she helped me get connected with CCT. She's helped me with my doctor's appointments and things I couldn't remember. She remembered about my medication and everything. Every time she comes, she look at my progress and she'd lie to me. Oh, Miss Treadwell, you look so good. Now, I just looked in the mirror. I know what I look like. But she'll lie to me and, oh, you look so good. You look so much better.
Her skin got brighter and she's putting on her makeup and everything.
I'm using a little lipstick. My health has improved tremendously, Tiara can tell you. And I really appreciate her help. No one seemed to have cared about the quality of my life until Tiara came into it. I love her. I wish I could keep her.
Shut up, Miss Charlotte.
People who become community health workers are highly motivated toward helping others, but they also want to help themselves by working at a job that averages $13 an hour plus health benefits.
And a number of the people that we've employed in the past have lived really at the poverty level and have been unemployed for a long period of time.
I was a stay-at-home mom. I was out of work for 3 years.
I was unemployed for 2 years.
Before I entered the program, I was unemployed. However, before I became unemployed, I was a property manager.
I graduated from community college with my associate's degree in human services and behavioral health. I was laid off after 6 months of employment.
I went to University of Pittsburgh for 5 years, so I have an associate's degree in liberal arts, and I'm a few credits short of my bachelor's. So.
And I thought this would be an excellent opportunity to give back to the neighborhood.
Being from the community is very helpful in this position because you know what the community needs. And you know the transportation issues. You know that struggle that a lot of the community do have.
I'm not the typical doctor that they would see. I'm not the typical social worker they would see. I'm someone whom they could relate to.
And I'm able to find different things in the neighborhood that people need, and I need it.
The training was intensive, and it was around 6 weeks.
There were like hundreds of applicants.
You had to do a math test, you had to do an English test, you had to take classes at the Career Link in interviewing techniques and how to write resumes.
At the end of the day, I feel fulfilled, I feel satisfied, I feel effective.
So I'm not only helping my community, but I'm helping myself and my family as well.
It's like I'm adding years to their life.
My grandmother always used to say, the space we occupy is the rent that we pay. And so I occupy space here, and I want to serve. And that's exactly the way I took it.
Community health workers are popular in many third world countries, but underutilized in the United States. Temple strongly believes this is an idea whose time has come, and they are convinced that the community health worker concept is a viable, long-term solution to the rising cost of health care.
Sometimes my patients say that I'm their angel, and it just tickles me so much, because it's really a blessing to hear something like that.
So I sometimes think one picture's worth 1,000 words. That's one of our first community health workers. Let's see if I can get on to the next slide. Okay. So we started this program 2 years ago, and we specifically looked for welfare to work recipients. We trained 3 cohorts of students, and we have 55 people now gainfully employed throughout Philadelphia in every major health system. And their salary is about $13 an hour plus full benefits. So they're getting health coverage, which they never had before. A number of them have tuition reimbursement for themselves and for their children. And it's very exciting to see them go back to school. The criteria for the program is a strong desire to help people. We look for people who are lay leaders in their community. They go through a 5-week intensive full-time training program. They don't get paid for the training. We need people who have a minimum of a high school diploma, and we test them in math, reading, oral and written communication skills, and basic computer skills, because they're allowed to record information in the electronic health record, so they need some basic computer skills. The mean income level of people who entered the program was about a little over $11,000 a year, and the median was $7,000 a year. And they had many, many months of unemployment before they entered the program. Some of them were living on the street, some of them were living in shelter, some of them were sleeping on their friends' floors. This was a really game changer for the students that we took into the program. So it was a 5-week full-time curriculum. They said it was the most intensive thing that they ever went through. They had homework assignments, reading assignments, quizzes, writing samples, and we were able to give them 3 undergraduate credits at Temple University for successful completion of the program. And we're in the process of applying for state accreditation, which theoretically will allow them to be reimbursed. Core competencies are communication and interpersonal skills, patient advocacy, HIPAA rules, service coordination, how to use community resources, and most important, how to remove the psychosocial barriers that contribute so much to poor health. How do you get transportation? How do you get child care? How do you get food? How do you get housing? We can take care of the medical conditions, but if we don't eliminate these barriers, we're not going to make people healthier. So we've modified the curriculum over 3 iterations, much more emphasis on interviewing skills, communication, documentation, and records. And we've devoted a lot of time to psychosocial determinants of health. After they go to work, we've had them come back for 2 hours a week for on-the-job training to fill in gaps in their knowledge, to help them form a tight-knit group where they can rely on each other for resources. And some of the topics that we've covered are these on this slide. And one of the things that we've learned is that each job is really quite unique, and that there are some general skills that we can give them, but a lot of the training has to occur at their site of work. So I'll tell you some of the places that we've put them in Philadelphia. So a couple of them are working in primary care offices with the highest cost patients to help locate resources for those patients and reduce the number of ED visits for ambulatory sensitive complaints. We've put them into a high-risk maternity clinic to help get appropriate prenatal care and decrease the incidence of premature deliveries. We've put them into a newborn nursery to help new moms and babies get their first postnatal appointment. We've put them into a cancer center to work with people who've had positive mammos, positive biopsies, positive colonoscopies, and have been lost to follow-up. We've put them into primary care practices to improve HEDIS measures so the practice could increase the pay-for-performance dollars that are received. They've worked in the hospital, patients with chronic illness, most specifically congestive heart failure, now pulmonary disease, who are frequent flyers to the hospital and to the ED. We've put them in specialty practices to work with patients who are frequent no-shows. And then we've put them in a pediatric hospital to work with patients who fail to show up on the day of surgery. And I'll tell you some of case studies and tell you some of the results, and some of them are good and some of them are not so good, and some of the lessons that we've learned. So we looked at 53 frequent flyers with chronic illnesses in the Temple health system population. We assigned community health workers to these patients. The initial contact was face-to-face. We think that's really important. We don't like telephonic case management. They went to the patients' homes. They met with them. They accompanied them to doctor's appointments. And they made telephone calls, sometimes daily, but their initial contact was face-to-face. And we looked at records 6 months prior to the intervention and 6 months after the intervention. So this is hospitalizations. 53 patients with 2 or more hospitalizations in a 6-month period prior to interventions. So for this 53 patients, there were 388 hospitalizations pre-intervention and 103 hospitalizations post-intervention. And then we looked at ED visits for 2 or more hospitalization population, 182 ED visits pre-intervention and 44 post-intervention. Then we narrowed the group and we looked at patients who had 3 or more hospitalizations in a 6-month period. So for this group, 46 patients, they had 374 hospitalizations, pre-intervention, 96 post-intervention. ED visits, 175 in the 6 months before intervention and 44 after intervention. So this theoretically is a tremendous return on investment. But the flaw with this data is we can't rule out regression towards the mean, because there's case management in the hospital. So what we need to do now, what we're doing, is trying to match this group with a similar cohort, age, sex, disease burden matched, to look at the decline in hospitalizations and ED without any interventions to make sure that this effect is real. So we have a lot of disease management programs at Temple, and there's a subset of patients that are assigned to an RN nurse navigator and a community health worker. And I'll show you this data. So this is congestive heart failure. So these are patients here. The CMS expected 30-day all-cause readmission, a little over 25%. The hospital does a reasonable job, 20% readmission. Social worker intervention, no difference, 20%. And this is an RN navigator and a community health worker. The problem is that this holds for 30 days, and after 30 days, when there's no longer this intensive intervention, the readmission rate jumps up. And we're going to be penalized for 60 days and 90 days intervention. So the learning from this is you've got to stratify the patients, figure out which ones need intervention for 60 days, 90 days, 6 months, so you can keep this low readmission rate going. So this data looks good, but I'm trying to tell you the pros and cons of all the data. Okay, so HEDIS scores. Our outpatient practices, our own practices, get a fair amount of pay-for-performance dollars because of improved HEDIS scores in the outpatient setting. And so in one set of primary care practices that's a hospital-owned, HEDIS measures were worth $83,000 a month, and the practice was receiving only $29,000 a month. So they were leaving a lot of money on the table. So they hired a community health worker who went through records and looked for patients with gaps in care, and they scheduled appointments for dental visits, well child visits, diagnostic studies, lead screening, pap smears, mammos, eye exams for diabetics. And so here's a typical example of what they did. One community health worker called 263 patients over a 4-day period who needed pap smears. And our patients, I don't know if you have similar patients in your clinic here, they have disconnected phones, they have the wrong phone number. So 65 calls were disconnected, 81 they left voicemails, 28 no answers, 25 already had a pap smear at another facility. But she was able to schedule 64 patients for making phone calls over a 4-day period, which is not a bad yield. And I mean, that translates to real dollars. Then we used the community health worker to try to decrease low acuity ED visits. And this is another HEDIS measure that we get paid for performance. So they received $4,900 a month for decreasing low acuity visits. So the community health worker called these patients, provided transportation, child care, and they increased the monthly payment from $4,900 to $8,100 a month. So that's a significant return on investment. Cancer navigators. So we have patients who just get lost to follow-up. Over a 2-month period, we identified 27 patients who had a positive screening exam and then were lost to follow-up. And the community health worker was able to bring 14 of these patients back into the system for treatment, which is a 52% yield over a 2-month period. And plus, she saved these people's lives. One of the places where we have community health workers is in a pediatric hospital. And over a 10-month period, 513 patients had cancellations or no-shows on the day of surgery. So this is about 50% of the total surgeries scheduled. Very high-risk population, non-compliant. You can imagine how expensive this is. So the OR is waiting, the surgeon's waiting, the anesthesia's waiting, the PAC is out. So she called up all the patients who missed their surgery, and 14% of the patients said they needed help. And of those 72 patients, 56 already had surgery, and 13 are scheduled for surgery. So then I had them look at the 441 patients who declined help, and of those, only 55% rescheduled surgery themselves. So we have 2 students from a business school doing a capstone project trying to calculate what the return on investment is for that. But it's pretty significant. We went from 77% rescheduled surgery, completed surgery, versus 55%. So how are they used ineffectively? At one medical specialty clinic, we have a huge no-show rate, and the community health worker called patients 3 times if they failed to keep 2 or more appointments. They called 50 patients. They matched them with 50 patients who were not called, and there was no difference in no-show rate, still 35%. This is a poor use of them. They're just making telephone calls. They're acting as secretaries. There's no rapport that's built between the community health worker and the patient. Inappropriate way to use them. We believe telephonic disease management doesn't work. We need to risk stratify patients, We need face-to-face contact. You really need a relationship with the patient. And if you just use them as an inexpensive secretary, you're giving them a job, but they're not doing what they're capable of doing. We assigned a community health worker to a newborn nursery, and right after delivery, she met with the mother and scheduled an appointment for the newborn baby within 7 days of delivery. She interacted with 300 patients over a 2-month period. The no-show rate was 30%, same thing as if she didn't interact with them. So again, very brief encounter, no rapport built, no follow-up, and it didn't affect the no-show rate. So a single contact right after delivery is not effective. You need an ongoing relationship, and probably you need to make a home visit to see the mother in her home and make sure that the mother and baby keep the follow-up appointment. So what are the obstacles? I don't know how it is here, but there are multiple silos at Temple. There's care management on an inpatient setting, care management on an outpatient setting. The primary care practices don't necessarily talk to the patients when they're in an inpatient setting, and you really need to align incentives. And I think that won't happen until the payment system changes between inpatient setting, outpatient setting, primary care physicians, and patients. And to do this, you need a learning curve. We made a lot of mistakes, and I think we've learned from the mistakes, but some of the places where we place community health workers initially probably are not going to show a return on investment. So over these 2 years, we've tried to figure out what works and what doesn't work. The lesson is that from the highest level of the organization, population health has to be a key strategy. And you sort of have to take a leap of faith. While we're living in a fee-for-service environment, you have to act as though you're living in an at-risk capitated environment. And even though we're billing for everything we do, we've got to figure out how to bill less. And, you know, it's a real misalignment of incentives. So we want to keep people out of the hospital, but the hospitals say fill the beds. You need good data. The data needs to be transparent. You need an infrastructure. And you really need to look at psychosocial determinants of health, education, food, housing, safe place to play, exercise, place for people to be able to study. To manage this program, you need to risk stratify the population and figure out who you're going to work with. You need intensive case management for maybe the top 5% of the patients that account for 50% of the healthcare spend. The contact has to be in person. You need to develop that personal relationship. It really helps to use people who live in the community, who look like their patients, who've gone through the same issues that their patients have. They're an incredible network on how to access community resources, and telephonic disease management doesn't work. The community health workers need to be very carefully monitored, and they need to be mentored. A lot of these people haven't worked for a long period of time. You have to talk to them about how to dress and how to talk to patients and how to clean their nails and how to comb their hair and not to walk around with earbuds in their ears, things that, you know, we take for granted. But if you haven't worked, nobody's told you that. The job description and the expectations must be very, very clear and must be carefully monitored. So I think this intervention is very effective as part of a care management strategy for the highest cost patients, but we can't forget about the next tier of patients who might move to the highest cost. There's this constant movement, between the highest cost patients and the tier just below that. And for those people, we certainly need to be able to do education, email, support groups. So my summary of this is that it's a wonderful program. I really think it can improve health care and decrease costs of the highest cost, highest risk patients. You need to use this resource wisely, not use them as secretaries. It's okay if they're secretaries because at least you're getting them off the welfare rolls, but they can do much more than that. The community health worker gets tremendous gain from this program, as does his or her family, as does the community. It's good economic development for the community. Of the first cohort of 34 community health workers that we graduated, 8 are now completing their undergraduate degree, and 3 have enrolled their children in college. And at a minimum, we can return people to work, but at a maximum, I think they have much greater capabilities. The program is very scalable. The curriculum is written. It's good. It's got learning objectives. It's got good evaluation. You really need a robust database to monitor, process, and outcome measures. And if you implement this program properly, I think there's a significant return on investment. Thank you.
Thank you so much, Dr. Stillman. Very nice. I think we've been discussing over the past months here in Grand Rounds and in other areas how healthcare is trying to move in a certain direction. And there are few courageous people and centers trying innovative approaches to address the problem. Okay. I like this very much. You're helping people off the street to get other people out of the hospital. I wanted to, by the way, I like that concept of the space you rent is the space you occupy is the rent you pay. I like that concept a lot. You're using also a little bit the scientific method. No, you have a hypothesis, you do an intervention, you test it, it didn't work, you move on to the next one. I like that approach.
Thank you.
We talked also about alignment. Let's talk about that.
Okay.
One of the problems we see in many systems, ours included, is that a system is really fractured in the sense that the people or the groups that engage in a certain approach may have a tremendous positive impact to the system, but the investment is not recovered by that group who invested in it. Mm-hmm. In other words, that an intervention keeps people out of the hospital, but those are two different systems. Mm-hmm. So we invest the dollars, but the hospital gets the benefit, may not transfer dollars back and forth, and vice versa, by the way.
Exactly right.
How do we move in that direction?
Okay. So it depends how rapidly you think we're going to be moving towards an ACO-like type structure. I think within the next couple of years, a significant percentage of the population that we take care of will be paid for on some kind of a global fee. And we're going to have to align incentives between the hospital, the doctors, the patients, the primary care providers, and realize we have the set amount of money to spend. And if we spend it by repeating CAT scans because we don't like the one that was down the street, or by hospitalizing patients for everything, or doing ambulatory surgery in an inpatient setting, we're going to use up that dollar really quickly. And that's really that seesaw type of thing. The most progressive healthcare systems, I believe, from the very top leadership say, we know we're moving in this direction. We can't turn the switch on overnight. We've got to learn how to manage this population. And so even though we might not be billing as much as we could, this is where we're going, and we've got to learn how to do this. But if we're, if the inpatient and outpatient don't talk to each other, there's terrible conflict.
Absolutely, absolutely. Question over there, then we'll go over here.
Sure. Yeah. Yeah, two very important questions. So I think the ratio, so the first question is, what's the ratio of the number of patients that each community health worker can handle? We think probably 100 over the course of the year, but not all at once. So some patients require more intensive intervention than another. So it's kind of, waxing and waning with who they intervene with. And we think that a supervisor who's usually an RN can probably manage about 5 community health workers. So the way I try to sell this to systems is that if you have one case manager RN, how many patients can that person handle? for the second RN by 3 community health workers, and you've now gone up to 300 patients at least that can be handled. So this is a lower cost intervention to handle the non-medical clinical decisions that contribute to improved health. And then the second question is, as we're cutting social network programs, how is this consistent with that? And I think, currently I'm working for a Medicaid managed care organization, and they spend money on food, transportation. If you can't get to a doctor's appointment, they'll send out a van to take you to the doctor's appointment. If you can't go there because your kids don't have babysitting, they'll pay for it. So I think people are, as we look at global amount of money to take care of the population, people are beginning to realize how important these other issues are in keeping patients out of the hospital, out of the ED, and being compliant with visits and medications.
You're going to have to repeat that.
Thank you for coming this morning.
My darling child said, "Thank you for coming. This was provocative."
Brilliant.
I'm so glad I didn't embarrass you.
One of the challenges that I think we all have here in not so much control the costs of that, but also being seen about patients' care profiles that are keeping off city to do that for the purpose of very organized. It's kind of scattered. It's a system that kind of affects it's usually with systems that have access to records.
So, it's a really good question, and it depends who's got the leverage and who's in charge. I think as we move forward, many of the ACOs are going to be formed by groups of primary care physicians, and then they will be able to dictate rules of engagement with hospitals. So if your rates are too high, I won't send my patient to you. If you don't call me up when my patient comes into the hospital, I won't send my patient to you. If you don't send me a discharge summary within 24 hours, I'm not going to send my patient to you. So there will be narrow networks of vertically integrated systems with preferred providers. We're already seeing that I've looked at things from so many different perspectives. In the past couple of months, I've looked at it from the insurance perspective, and they have lists of specialists who are in network and those that are out of network. And if you go to an in-network specialist, your copay is greatly reduced. And they pick people that are responsive, that have high quality, that don't milk the system, that don't put tubes in every orifice or catheterize every single vessel. And this is happening. And then they're doing carve-outs for, I think there should only be one one cardiac transplant program in Philadelphia, and everybody contract with them at a set rate, demanding a certain quality, demanding that if something goes wrong, the patient will be brought back and taken care of. So I think we're developing horizontal networks of primary care providers and then narrow vertical networks.
Saw a question up there, then we'll come back here.
So I think it's really interesting concept that sounds a lot like the goal of the managed care system that was proposed about 20 years ago. So why is this good for the managed care system, number one? And number two, what does that?
So he says it sounds like the old HMO days. I think this is different, and I'll tell you why and who's paying for it. In the old HMO days, you were paid the same amount per patient per month, regardless of the disease burden. With newer payment systems, you're paid more for patients who are older, sick, or higher disease burdens, and that rate is adjusted every year. And some people game the system. They upcode so that the following year they have a sicker population. They could be paid more capitated dollars for that population. But I think we have to be careful. And who's paying for this? A lot of different people. Some of these positions are paid for by insurance companies who expect to see a return on investment. Some of them are paid for by the hospitals as part of a care management strategy. Some of them are paid for by groups, large groups of physicians who are incentivized either with improved HEDIS scores or keeping low acuity patients out of the ED. So I think you have to follow the money and then figure out who's going to pay for this.
So I actually don't have a question, but I have a comment. One of the comments a few months ago was about one of the things that I thought was very interesting, I think that as physicians, you know, with our social obligation, and I recall a pediatrician at Louisville University who noticed that a lot of her children were underweight. And so she tried something called growth. And essentially what she did was, with a social worker, she decided to meet with Louisville University and like a team plan that would be sort of highlight plan. And the anticipation was that 100 families per month. And when we left Louisville University in 2012, there were 7,000 families per month that got and essentially, you know, this one physician had the idea, and she knew there was a problem. So I think that also there's a challenge to us as we've seen networks being applied, trying to figure out how to solve this ourselves and have an impact on keeping our patients healthy and not only providing care, but also providing education.
So my other darling child is speaking, and I think, you know, we need your brains to come up with the ideas, but then you can hire much, much lower cost people to implement the program. And that's the point I'm trying to make, that you use the lowest cost person to his maximum level of competence. And if you use people of the community and from the community, they have more credibility and they know a lot of resources in the community.
Questions, comments at here?
When you're looking at what specific interventions the health workers are making in home preventative, you know, some of those things, you know, behaviors of the patient engagement can change.
Right.
So that empower the patient to take full charge of their own health care.
Right.
And not have to depend on even a low cost, but a cost person that could then be moved somewhere else and use the same intervention somewhere else.
Yes. Yeah. So they go into the homes with checklists. You know, I just kind of skimmed over the program, but they have very detailed checklists. They record what they do. They record the education that they provide.
Questions? I wanted to ask you a more complex question, something that you may have to think about. You've been in healthcare for quite some time. You've been in leadership for quite some time. You've engaged in developing new programs. What have you learned about how to move in systems, not individuals, not a group, an entire system in a direction that you feel is the appropriate direction that is aligned with the needs of the population you serve? How do you move a system? What works? What doesn't work? Think about it for a second.
You know, I've thought about it a lot. You know, it's a very powerful question. I think you need leadership at the top. And if the top says, here's my flag, rally around my flag, this is the direction that we want to move in, you can get the troops to follow. If the top leadership doesn't feel this is important, it's very hard to get the next level of leadership to carry on. So it has to come from the highest level of the health system. I recently visited Montefiore Hospital in the Bronx. Some of you know that. No, it's a wonderful, wonderful program in population health, but it's from the highest level of leadership that this is their stamp of excellence. This is what they do. And if you don't want to think that way, well, then don't go to Montefiore. But it's hard to have a lot of competing interests in the health system because we can't do everything well. We have limited resources. Not every hospital has to be a quaternary tertiary care hospital and decide what's important to that health system, but it has to emanate from the top.
Well, really, I really want to thank you for being here today and wonderful lecture. But I thought you were going to say that what you needed was brutal force to get the system to work. It is my goal as chairman to ensure that every institution has a slugger bat. So now we have Temple included here. Dr. Paula L. Stillman, Medicine Ground Rounds, University of Louisville, March 20, 2014. Do what I say or else. Thank you very much.
Thank you, sir.
Thank you for coming. That was wonderful. Thank you all.